Good afternoon, everyone. I'm Dr. Paul Lombardi. I'm the medical director for joint replacement here at Morristown Medical Center, and I'm also the president of Tri-County Orthopedics. It's good to see a lot of familiar faces in the audience, and so I am tasked with telling you everything about osteoarthritis, rheumatoid arthritis, avascular necrosis, and everything to know about hip replacement in a half hour. So I'm going to do my best. Okay. And certainly at any point, stop me if you have any questions regarding, anything you want to talk about. So first slide is I do not have any disclosures. I do not work for any company. I don't consult. I don't teach. So anything that I implant in any patients, because I think it's in the patient's best interest. So just a very brief review, which I'm sure you've already heard. All right, the hip socket is a diarthrodial joint lined with synovium, very thick capsular attachments. And why this is relevant is osteoarthritis is a disease of the cartilage, right? Just like you take the rubber off your tires, you take the cartilage off of your femoral head. Whereas all of the inflammatory arthritis, right, rheumatoid arthritis, psoriatic arthritis, and so forth, that's a disease of the synovium. That's why that distinction. And also, just in general, most patients don't really, when you see patients in the office, most of them don't even know where their hip is, right? How many patients come to the office and go, my hip hurts? Well, that's not where your hip is. Your hip is here. Hip pain is groin pain. That's why it's very important to educate patients as to where the hip actually is. Dr. Spinicky gave a brief chat about this, but this is important. Blood supply to the femoral head is very important when we discuss avascular necrosis. Okay? One aspect of it, what Dr. Spinicky was talking about, is through trauma, right? When you break the bone at the level where the blood is coming into the femoral head, you can get avascular necrosis. There are some other reasons why, but the femoral head anatomy, blood supply anatomy is very important. And most of the blood, 60% of the blood supply comes through the lateral femoral circumflex. So if any of you are taking your boards, and that's a question, 60% of the blood comes through the lateral femoral circumflex. Surface anatomy is very important when you're examining a patient. Okay? You have to know where the greater trochanter is. The tensor fascia lata, that's another name for the IT band. Right? The muscle is the very proximal aspect of the IT band. And many patients with bursitis of the hip, which is probably one of the most common things I see in the office, will have sensitivity of the greater trochanter going down their thigh towards their knee, or reading up towards their buttocks. Okay, the sacroiliac joint, right, is where the pelvis meets the spine, and the inguinal ligament is very important, because if I have a patient with pain above the inguinal ligament, that's not orthopedics. That's either general surgery or obstetrical. Below the inguinal ligament is where I live. Physical examination. Most important that I deal with as an arthritis surgeon is internal and external rotation. That's where patients with arthritis really have pain, internal, external rotation. And then flexion, extension, abduction, okay, but certainly internal, external rotation is where patients have the majority of the loss of range of motion. And a good clinical pearl is when you're examining a patient, and a patient with osteoarthritis will not be able to flex in line with their body. So as you're flexing their hip, they're also abducting at the same time. So a patient with osteoarthritis is unable to move in this direction, in plane. They have to move like that. And if you hold them, it's very painful for them. So that's a very good physical examination pearl on how to examine a hip, particularly with flexion and extension. Also, a good clinical pearl is when someone comes to your office with knee pain, many times that can be their hip socket is the exclusive cause of their knee pain, because the obturator nerve supplies the hip and supplies the knee. So some patients are wired in such a way that hip socket pain will give exclusively knee pain. So if you're examining a knee, always give a little cursory kind of internal or external rotation to the hip socket, and I'll bet you a couple times a year you're going to discover hip pathology that you otherwise wouldn't have really known about. Osteoarthritis, the most common arthritis that we see, can be secondary to previous trauma, something called developmental dysplasia, used to be called congenital dysplasia of the hip, politically correct, infection. But this is the typical X-ray appearance that you would see, which is significant osteophyte formation, superior lateral joint space erosion, and subchondral cysts. Okay, this is the typical severe osteoarthritic hip. And in your history, these are the things that patients will tell you. They can't put on their socks and shoes. So I initiate this. So all the patients think I'm Karnak. You know, remember Karnak from Johnny Carson? Because I know exactly, oh my God, how'd you know I can't do all that? Because it's extremely repetitive, right? These patients cannot put on their socks and shoes. They'll say, yeah, I walk 20, 30 feet, I have to sit down. I can't go, particularly downstairs. Patients can go upstairs, but they have a hard time going downstairs. And you'll see a leg length is usually a little off by about a centimeter, and they have something called a Trendelenburg Gait. Now, Trendelenburg Gait, when you see patients walk, they'll walk kind of like this. They'll walk and they'll, so if it's my right hip, they'll bob to the opposite side. They'll bob to the opposite side. You see patients, sometimes you see them in the supermarket. That's a hip limp, okay, as opposed to an antalgic limp or coxalgic gait. So patients will just, that hurts. Oh, I don't want to walk on that. Whereas a hip pathology, patient, you have to watch, when evaluating gait, I'm always looking at the center line, okay, where the patient's forehead is. Because if they're coming off the center line, like this, I'm always suspecting that hip pathology. As opposed to Trendelenburg sign. Trendelenburg sign issue. The patients have weakness in their abductors. And what will happen is in Trendelenburg Gait, patients will bob towards the affected hip. Trendelenburg sign, the hip will tilt to the affected side because those abductors aren't working correctly. Those patients many times have spine pathology or it can be from a previous stroke or some other neurologic condition. So conservative management in osteoarthritis, once again, osteoarthritis is a disease of cartilage, okay, which is anti-inflammatories. And I know you're probably all thinking that orthopedists give too much, but we actually do concern ourselves sometimes with the elderly to make sure that we look after their renal function. Low-impact exercise program. And this is not hokey. Really, one of the best exercises you can recommend to your patients who have hip pathology is yoga, okay, is yoga. Ultrasound-guided cortisone injections, okay, are useful not only for treatment, many times for diagnosis, right? Many times when we're examining a hip, is it the hip? Is it the knee? Is it the back? Is it all together? Because sometimes these patients are complicated. Many times an ultrasound-guided injection can help you diagnose this. So if you do an ultrasound-guided injection of a hip and all that pain goes away, wow, doc, I feel like $1 million. Well, then you help them, but you also know that that is their problem. It's their hip socket. So many times I'm very liberal in doing ultrasound-guided injections because it helps me in diagnosis, not just with treatment. So we offer this because there are sometimes patients who can't have a hip replacement for whatever reason, or they're just looking for temporary relief. You know, my daughter's getting married. I don't want to look like Quasimodo going down the aisle. What can you do for me? Well, you could do one of these injections. And cortisone injections of the hip are just not as reliable as cortisone injections of the knee. But it's certainly something to offer patients. Now, past that, now this might be just my opinion, but I really think it's the truth. There's really no role for any other kinds of injections. Synvisc or any other substitutes are not FDA approved for the hip socket, okay? And there's a lot of very fancy, slick websites and medical practices, actually, that do stem cell injections, fat injections, PRP, you name it. That's all bogus. It's all bogus. And it's designed to extract the money out of the pockets of patients who are the most vulnerable, the ones who need a surgery but don't want it and will try anything possible not to get on the operating table. That's who that's designed to attract. And those things are very expensive, $2,000 a pop for one of those injections, and they don't work. In inflammatory arthritis, okay, the most important element of inflammatory arthritis is you do not see osteophyte formation. It's exclusively loss of joint space. Okay? So if we go back a couple of slides, right, osteoarthritis, you see osteophytes, you see these big, huge subcondylar cysts. That's your classic osteoarthritic hip. The classic rheumatoid hip or psoriatic arthritis or any of the other inflammatory arthritis look very similar to this, in which you have near complete joint space elimination without osteophyte formation. And certainly, since it's a disease of the synovium, it's absolutely imperative to maximize medical management. And I guess that's supposed to be TNL. That's pretty funny. But all the new medicines for the inflammatory arthritis are excellent now. So certainly through your medical practice or through rheumatology, to maximize medical management is really what you need to do for rheumatoid patients or the psoriatic patients because they're very effective. And the physical exam is very similar. Just a clinical pearl, ankylosing spondylitis is something that we do see in our practice. And if you have a patient who you suspect has ankylosing spondylitis, many times it looks very similar to other spine conditions. Something called DISH can look very similar to ankylosing spondylitis. But if you see fused sacroiliac joints, where you don't even see them, okay, that is absolutely specific for ankylosing spondylitis. So just a little clinical pearl. Avascular necrosis. Avascular necrosis is a disease of the bone, not a disease of the cartilage. So that if you put an arthroscope into a hip socket that had severe avascular necrosis, you may actually find that it looks very normal. Because what you could think of it as an orange. Okay? The peel is the cartilage and the fruit is the bone. This is a disease of the fruit, not the cartilage. And other causes, so trauma was one cause. The most common cause we see in our practice is steroid use. It doesn't have to be for someone who just received a chemotherapy protocol. It could be someone who just received a Medrol dose pack. I have seen single-use steroids cause avascular necrosis. Alcohol use is the next most common. And after that, lupus, sarcoid, and I don't have many patients who are sponge divers or who are going down, getting Caisson's disease, but that's sort of the list of diseases that can cause avascular necrosis. So X-ray findings, you do not see very much by way of osteophytes. You see a flattening of the femoral head, and the very specific X-ray sign that we see is this right here. That right there. That's called crescent sign. Okay? When you see this crescent lucency in the superior portion of the femoral head, that is the underlying subcondylar bone and cartilage is lifting from the femoral head, causing that space. In MRI, what you see is a very distinct area of death of the bone. Okay, a very distinct area of death of the bone. Now, the one thing about avascular necrosis is that it's a one-time insult. It is not a progressive disease. So whatever bone died is dead. Unless the patient's taking more doses of steroids or is continuing to be an alcoholic, the death is not going to worsen. What worsens, and why this becomes a problem, is that bone is living, breathing tissue. It's constantly being renewed. So the body is not renewing that area, so what happens is it dies, it fatigues. Okay, just like you have metal fatigue, get bone fatigue. The bone just flattens out from the patient's weight because it just can't remodel that area. Stages of avascular necrosis. So, orthopedists, we love stages, we have classification systems, but the most important thing to know here, it goes from stage 1 to stage 4, where the most important stage is between stage 2 and stage 3. Stage 2 is patient has some depth of bone, but has maintained the geometry of the femoral head. The femoral head has not been deformed yet. Once you go to a deformity of the femoral head, like in stage 3, that's when the types of treatment changes. Okay, once you hit stage 3 to stage 4, it's really talking about a hip replacement. Before that, there are some other things that can be attempted. So once again, in these different stages, this is normal. This is maybe stage 3. You see some flattening. And stage 4, sometimes even stage 5, is when you have avascular necrosis, but now you have changes in the socket as well, where because the femoral head now is no longer round, it's not particularly nice to be rolling around in there, it causes arthritic changes then in the socket. And that's end-stage avascular necrosis. So for stages prior to collapse of the femoral head, there's something called core decompression, and the theory behind that is that you can, drill a hole into the femoral head, and then you're allowing healing to occur, where then, where tissue and blood vessels can now get into this area to try to basically put tissue in there that can remodel, right, so that the flattening no longer occurs. Patient has to be non-weight bearing because you're putting a big hole in the bones. Patient has to be non-weight bearing for at least 6 to 8 weeks. Something else that's been attempted is fibula grafting. Okay, we take either a cadaver piece of fibula, a cadaver fibula, or you could actually take a vascularized fibula from the patient and introduce that into the femoral neck and head. As time goes by, this seems to be just being done not quite as often, only because now hip replacement has become such a successful operation where these operations have a significant amount of morbidity associated with them. This is starting to not be used as much. So before I get into hip replacement, does anybody have any questions or concerns about what I just spoke about? Yes, ma'am. So the question is, if you have a fracture of the hip in 3 parts, can you develop avascular necrosis? So the answer to that is, so when Dr. Spinnicky was talking, you could have a fracture of the femoral neck, and then you have the intertrochanteric fractures. The intertrochanteric fractures are the ones that go on to have multiple pieces. And those patients generally do not go on to avascular necrosis because the fracture is usually below the blood supply. And when I counsel patients, because many times patients who have the 3 or 4-part intertrochanteric fractures will ask, how come I'm not having a hip replacement? Because fractures that are required to be fixed cannot and shouldn't be replaced. Fractures that need to be replaced shouldn't be fixed. Yes, sir. So there's a lot of theories behind this, but the one that seems to be the most probable is release of fat into the bloodstream. And what happens is it gets, as the capillaries cone down to smaller and smaller sizes, that the femoral head, for whatever reason, is very susceptible to it. But it's not just the femoral head. I think it may be the metaphyses of the ends of long bones, because we see avascular necrosis in the proximal humerus. We see it in the distal femur. Certainly patients who have had significant chemotherapy protocols or large doses of steroids, they could develop AVN in just about all of the major heads of the long bones. But that's the going theory, is that there's basically a fat embolism into the blood supply of the heads of the bones. Yes, ma'am. So the concern is there some sort of dose-dependent, is there a dose of steroids that you feel are dangerous versus not? And the answer to that is no. And certainly, I don't want to make you all fearful to not prescribe steroids. They're very important medications. And there is some very good statistics that show that the majority of avascular necrosis is silent. All right? It's such a small portion of the bone that gets affected that the only way we ever really discover it is by doing an X-ray. Say a patient fell and has a contusion, and you get an X-ray. Oh, you happen to have avascular necrosis. Did you ever know that? It turns out to be an incidental finding. But there are no studies that talk about dose-dependent avascular necrosis. If you give 10 milligrams, you're more susceptible than if you give 20 milligrams. It's just some patients, my own personal feeling is I think some patients' vascular anatomy makes them more susceptible than someone else's. Because sometimes we see patients who dislocate their hip, and some go on to avascular necrosis. Other patients dislocate their hip, and they never have a problem. Okay, hip replacement. And it's not just because I do them all the time, but certainly it's considered one of the most successful operations that medicine has ever come up with. And that's with respect to relief of pain and more important, the restore, that we restore function. So we're going to go over some of the indications, the pre-op and the post-op considerations, some of the materials, and we'll hit on some of the operative approaches. Indications. The X-ray is only for diagnosis. As a joint replacement surgeon for 20 years, I very rarely tell someone, you should have your hip replaced. Okay, the X-ray, because patients will always gravitate towards the X-ray. What does the X-ray show? Does the X-ray mean I have to have a hip replacement? Well, no. The X-ray just gives you a diagnosis. But certainly prior to, you should have, the patient should have tried anti-inflammatories, exercise programs, and weight loss, because they do work. Okay, because they do work. And generally how I counsel patients is your lifestyle being negatively impacted on a regular basis? If the answer to that question is yes, you should start to consider it. Because it's very important, not just for a hip replacement, for any operation. The patient has to be behind it. They have to have made that mental connection. While I really don't want this, I think I need this, and it's time for me to go. Whereas if their family's dragging them, or the doctors are dragging them, or I'm dragging them, they're going into the operating room like they're going to the chair, right? And that's not a very healthy way to enter into the operating room. So in the pre-op assessment, which I'm sure all of you do on a regular basis, the takeaway point here is there's a few things that have gone on over the last several years. One is sleep apnea. What we did, and when Dr. Dowling was chairman, we really looked into, okay, what patients are doing well, what patients aren't doing well. And what we discovered was undiagnosed, untreated sleep apnea was one of the largest determiners of someone who have a bad result. So if you have patients in your practice, and you can almost tell who does have sleep apnea, they kind of look like me, a little chubby, little short neck, And, but certainly prior to having any joint replacement now, if the patient has sleep apnea that's not diagnosed, that is an automatic rejection. You will not be considered for surgery. Hemoglobin A1c. I actually find it, I'm actually starting to do routine hemoglobin A1Cs on all comers. And I've diagnosed a number of patients now with diabetes that just didn't even know they had it, right? But we know that hemoglobin A1c above 7 or 7.5 puts patients at a significant risk for infection. So any patient who has that kind of, someone with A1c of 8 will not see the operating room. They have to do everything they can to get that back down. BMI and smoking. Now, personally, I think BMI is not a particularly good indicator to say who can, who cannot have surgery. But insurance companies don't think so. So Blue Cross and Blue Shield, and Aetna soon to follow, will automatically deny a patient for a hip replacement or a knee replacement for a BMI over 40. Period, end of story, no appeal. They hang up the phone. Call back when it's under 40. I'm sorry? That's elective, that's correct. For an elective hip replacement. If someone falls and has a fracture and has to have the hip replaced, absolutely not. But certainly, if their BMI is above 40, automatic denial by the insurance companies, as well as for smoking. If the patient's an active smoker, they have to show that they've stopped smoking for 2 months and will be nicotine tested the morning of surgery. The risks. So the risk of a hip replacement, infection, less than 1% in typical patients, unless they have any pre-existing conditions, diabetes and smoking. All patients receive antibiotics 1 hour prior to incision and for another dose for 24 hours. In my own particular practice, no dressing changes in the hospital. I don't want any well-intentioned people who just ate their roast beef sandwich probing my wounds, right? That's a great way to get an infection. So all my dressing changes, actually I don't do any dressing changes. Patients take it off themselves at home after a couple of days. The best guard against infection, okay, as a surgeon, is good technique, meaning you don't leave a lot of dead and traumatized tissue in the wound, and surgical operative time. That's been shown through multiple studies in Medicare that surgeons who do a larger volume of procedures and can get their operative times under a certain amount have less infections than surgeons who take 2 hours or 3 hours to do a hip replacement as opposed to 40 minutes. Blood clots. The chance of a significant event from a PE now is around 0.05%, and there is no indication anymore for routine Doppler exams. Typically now we're giving aspirin, 325 milligrams twice a day, and in patients who are in the elderly, we're doing baby aspirin twice a day, and this has been shown through our literature to be very effective at holding off DVTs. Patients who have obviously other conditions, we're more aggressive with Xarelto or Eliquis and those type of medications, but they do cause significant hematomas. Okay, and patients don't particularly care for them, but obviously that's very important. And as time goes by, greenfield filters are now, there's very few indications for greenfield filters, because you see it all over the television with lawyers and how they're causing significant morbidities. So now it's quite rare for us to do greenfield filters, even in patients who have had previous PEs. Dislocation. From the posterior approach hip replacement, it's around 2 or 3%. In the anterior approach, a little bit less than 1%. Nerve damage. In the posterior approach is the sciatic nerve that's affected most. In the anterior approach is the femoral nerve. Way less than 1% incidence of this issue. And in anterior hip replacement patients, they can develop numbness in the anterior of the thigh, which is unique to that particular operation. Half the population of the earth walks around with a leg length discrepancy, but in hip replacement, looking to get patients within a centimeter. Within a centimeter, your brain won't be able to tell the difference. The posterior approach for hip replacement is old reliable. That's been done now since the initial approach for hip replacement was an anterior approach, but was switched in the early 70s to the posterior approach. And there is just reams and reams of data that shows that the posterior approach is, and still is, a very good operation. Very reliable results. So when you say you have to detach muscles, you do have to detach. So in a posterior approach, the patient's head would be here, the foot would be here, and in this incision, you do have to take down the short external rotators in order to get access to the hip socket. You see how the short external rotators are folded back here. So in order to get to the hip socket, you do have to detach these muscles. Now, when you're coming out, you do reattach them, but it's actually been shown many times that doesn't even hold, that repair. So, but that is the muscle they have to quote-unquote cut during that operation. And in the posterior approach, you do have precautions. The 90-degree rule, pillow between the legs, high toilet seat. You do have to have that for the posterior approach. You do not have to have that for the anterior approach. The anterior approach is the least invasive kind. You spread through muscles much like you spread curtains to see a window and then sort of fold it back. In In my data, I have less dislocations and are much easier to establish leg lengths with the anterior approach. It can be done on an outpatient basis more often. There are surgeons who are doing posterior approaches on an outpatient basis, but this is the future. The future of hip replacement is going to be outpatient or 23 hours, certainly, as we go forward. And for the anterior approach, patients ask about this special table or no table, an x-ray in the operating room versus no x-ray, and this is all marketing bunk, right? You do a hip replacement the best way you know how you've been trained. Some people like the table, some people don't like the table. Some people like the x-ray, some people don't like the x-ray. You use the technique and the materials that make you the best surgeon you can be, whether or not you use these modalities or not. So questions about anterior approach, who's a candidate? Right? I hear that all the time. Am I a candidate for the anterior approach? So I used to do every patient through the anterior approach, but now I'm about 80%. Okay, I'm 80% because there's some patients who just aren't candidates. Someone who's had a previous trauma, someone who was born with a congenital deformity, okay, where the anatomy has been disturbed, or if their body habitus is such where they have a fold or a panish right where I'm going to operate. So I always tell patients, if I tell you that you're not a candidate, that's because my experience has told me that you're not going to get, you don't have the best chance at a good result if you try to fit a round peg into a square hole. And through any approach, all our hip replacements now are done spinal anesthesia with sedation. Okay, that's been shown to decrease blood loss and decrease DVT risk. Materials. So the biggest controversy is really the bearing. There's metal on plastic, metal on metal, metal on ceramic. These two, the metal on metal and ceramic on ceramic, were found not to be particularly good. The metals on metals were causing significant metal fretting, causing high levels of cobalt and chromium, and the ceramic patients were squeaking. So really, and you could hear it down the hallway, and you could hear them down the hallway. So now we've returned to metal on polyethylene. Some surgeons are doing ceramic on polyethylene, but certainly the bearing now of choice is the plastics. There's also cemented versus uncemented or hybrids. Most surgeons now are doing hybrids. Most surgeons now are doing uncemented replacements because technology now is so good. For patients with significant osteoporosis, then we're usually just cementing in the femur. Okay, with the majority of patients now, we're getting uncemented implants. So postoperatively now, we're sending 98% of our patients directly home. Okay, hip replacement patients do very, very well post-op. Knees sometimes are a little slow out of the box, but hip replacement patients really do very well. And it's quite rare to send patients to a subacute rehab. Everybody's getting up as soon as their block wears off, and patients, they see the therapist in the morning, they're able to get out of bed, get dressed, go up and down stairs, they're able to get out of a car, and they're able to go home. I personally do not use home therapy or home nursing. I found them to cause more problems than they were solving. Okay? If I had a dime for every phone call I got, well, the home therapist just left, I'm in agony, call me in something. So about 5 years ago, I decided, you know what, let me just not use them anymore. And what happened? Nothing. I didn't get those phone calls, and the patients were happy. So I just don't use home services for the majority of patients. So the bottom line on results, multiple studies, 90% survivorship at 20 years. But these were implants that we were putting in the 80s are showing this data. Every reason to believe that the implants we're putting in now could even last longer than that. And they last much longer in women than men for obvious reasons, because, men do stupid things, right? So as far as our hospital here, we do the largest volumes of hip replacements in the state of New Jersey. We're very proud of our program. The CMS considers us the best joint replacement hospital, in New Jersey. And that's based on not just our opinion, but our quality and our cost. So I wanted to go through a couple of patient videos here. Oh, boy, that's really nice. Can the IT guy flip these for me real quick? So. How am I doing for time? Wayne, am I running into time? I'm over? Okay. Yeah. Okay. Oh, we're ready? Oh, I'm sorry, question. Yes, ma'am. So the question is, what is the minimally invasive posterior approach versus the standard posterior approach? So a lot of it has to do with the size of the incision, okay? In my opinion, size of the incision is really a cosmetic thing. That's a psychological thing for a patient. You see a smaller incision, you think that maybe you have less surgery. There really is no such, in my honest opinion, no such thing as a minimally invasive posterior approach, because you have to take down the same muscles to get to the hip socket, whether you do it through a small incision or you do it through a larger incision. Well, for a posterior approach is a posterior approach. There's really no difference in how you're actually accessing the hip and the implants you're putting in. Anybody else with a question? Oh, I'm sorry, ma'am. So what I found when I was sending the anterior patients to physical therapy right away was they're developing a lot of anterior thigh pain. It's my opinion that I think the body just needs to heal. Those muscles need to heal. With a hip, physical therapy is not all that critical in the first month. Different than a knee replacement needs that therapy. But in the first month, what I found, I just want these patients to heal. And at the 1 month visit is when then I focus on physical therapy. All right, we're ready? I'll do these quick because I know Dr. Kalitsa. Okay, there we go. So this gentleman has an obvious problem here. He's doing something called scissoring. His hips are so stiff that he can't clear his legs when he walks. He was fired from his job as a forklift operator and was basically housebound. Right? And what I want you to focus on is his face. Look at that face on the left side. That's not a happy guy, right? And look at him here. He got his job back at the same place he was at, and he was really proud of the fact he went fishing with his dad for the first time in 20 years. Look at his face. That's a happy dude. Oh. Oh, wrong one. This is a gentleman who had an anterior hip replacement same day. That's the recovery room, right? That's the recovery room. He's dressed, he's ready to go, right? It's like, all right. So that was done at 7:30 in the morning, and he was leaving about 3 o'clock in the afternoon. Right? Right? This woman clearly is having a problem, right? Both hips. Okay. Is not just, she had to come in a wheelchair, but she had to go to x-ray, get a few pictures, and this is how she walks. Same lady 3 months later, right? Once again, look at her face. Look at her face, right? She's a happy lady. And I'd love to tell you it's because I'm so skillful. It honestly is not the truth. Because every orthopedic surgeon in this audience has the same videos I have, right? Because it's a wonderful operation. Because it's a wonderful operation. Right? This is a product of someone who was just terrified to go to the operating room. We talked about this earlier, how patients need to have their own little mental journey to get there because they're so fearful, right? And this is someone who obviously had the same problem. Right? The sound's not on, but on the way back, her daughter's talking. She's crying, actually. If you check her face, she's actually crying. Right? So I want to thank you all for coming and allowing me to talk. And this is the gratitude that we see as doctors because it's such a wonderful operation. This was a 21 nun salute that I got from one of my nun patients. And thank you very much for giving me time.